It's a great pleasure to introduce the next speaker, and this is Professor Bob Woods from the UK. He has been a practicing clinical psychologist and working with older people for a long time, 35 years, you say, training and working initially at Newcastle. And then Professor Woods moved to London, and currently he is a clinical psychologist professor at the Bangor University. And while he is very famous for all of his numerous publications, I don't think we have to say a lot. And he is talking to us today about European collaboration on psychosocial research, and he will talk about the example of the Interdem network, which is another interesting initiative.
So just to give you an overview of what I'm going to talk about, I'm very aware that here we are in a session about changing practice, and so hidden implicitly somewhere in the talk will be some thoughts about research into practice. And sometimes people say, well, there's no point actually doing any more research because we haven't put into practice all the research that's done already. And there's a truth in that there's so much that could be put into practice, but I don't think we should stop doing research on that basis because I think we need to keep trying to take the field forward. But implementation, as we'll see, is a big issue. I'm going to start by talking a bit about JPND, and I'll explain what that is in a moment, then talk a bit about psychosocial research and what that is, then tell you about Interdem, and then look to the future. So, JPND, the joint program, EU joint program on neurodegenerative disease research. It's a wonderful program. It's a response from European nations to a grand challenge. The other sort of grand challenges they're looking at are things like climate change and so on. And it's interesting that dementia is way up there with the big challenges of our time, and the sort of thing that can only be addressed by joint action between countries. And these are the aims of the program: improving scientific understanding of the disease, improving medical tools available to doctors to identify and treat the disease, and then the bit that interests me perhaps more, improve the social care and structures available to assist patients, people with dementia, their families and health service providers, so that people with dementia can receive optimum care at all stages of their illness. Those, of course, are the words of JPND. So I mention that now because JPND will keep coming up, and rather than having to explain or try to say joint program on neurodegenerative disease, which takes far too long, now you know what JPND is because it's quite important in the current context. Psychosocial research covers quite a wide range of topics. I suppose part of it is round about understanding more about the experience of living with, of adjusting to, of coping with a dementia for both the person who's experiencing the condition and those around them, their family, paid, informal, formal caregivers. It's also about how care services are organized to best deliver the support that people need. It's also about training and education for those who are providing care, and it also covers a wide range of specific intervention approaches which focus on psychosocial aspects. Now, dementia research, as many will know, is actually the poor relation of medical and health research. It's the Cinderella of research. These are figures from the UK, and they show pretty dramatically, I think, that in terms of the costs to the social and health care sectors, the amount that's spent on dementia research is minuscule compared with the amount that's spent on other conditions such as cancer. In the UK, for every person who has a cancer, there's £291 spent on research. For every person in the UK with dementia, £61 is spent. So if we look at the dementia field in the broad, then there's a real inequality in terms of its research funding. You can perhaps pick out your country on there. You'll see that I think Germany the UK and the European funding are the main sources of research investment in dementia. This is from one of the very excellent JPND reports that's available on their website. Obviously, that needs to be adjusted in a sense for population and GDP and so on. But if dementia research is the poor relation of health and social research, then psychosocial research is the poor relation of dementia research. And again, from the JPND report, the mapping report, we can see that most of the funding goes into basic research. If you look down at the bottom right-hand corner there, 81.2% goes into basic research. Clinical research, which includes a bit of the psychosocial, a bit of the treatments, but also a lot of other medical factors like brain imaging and so on, takes 12%, and health and social care research just 6%. So psychosocial research is the poor relation. Very little has been spent on it over the years. And you might think that's right, but I guess the best outcome would be a much bigger cake to slice up between the different sorts of research. This is a very busy slide, but again, I put it up because I don't just want to be giving you figures from one particular country, and it's always fun at these sort of events to try and pick out your country just before the slide moves on. That's why I'm talking a lot, to give you plenty of time to scroll down. This shows the balance in each country between basic, clinical, and health and social care research. So the health and social care research is the sort of purple colour on the right. On the left is the basic in green, and then the blue is the clinical in the middle. And you can see that there's some variation between countries. I think the Netherlands, if my eyesight is good enough, probably has the biggest proportion of psychosocial research of the different countries. The UK perhaps second there in proportional terms. If we look at the evidence base for psychosocial interventions, there's a developing evidence base, and there was a very good review, which is an open access review. You can just click on it on the web in the journal Dementia, just in 2010 by Javier Olazaran and colleagues. Many of those colleagues are Interdem members. And this did a very, very thorough systematic review of the literature at that time. It found 179 RCTs, that's randomized controlled trials, encompassing 26 different types of psychosocial intervention. And there was strong evidence particularly for individualized intervention packages for family caregivers. And the evidence was that would improve the well-being of caregivers and help delay admissions to care homes. And so there's definitely a trend. There's definitely more of these big randomized controlled trials becoming more common. There's a journal that just publishes trial protocols. That's where researchers say what they're going to do. And there were 14 last time I looked in that journal, and 13 of those that mentioned dementia actually were about non-pharmacological approaches. But one of the things that Olazaran and colleagues highlighted was the poor quality of the studies so far. They used these sort of quality standards. Did the study describe the participants fully? Did they use standardized diagnostic criteria? Was the intervention well described? Did they use validated outcome measures? Were the effects measured by blind and independent assessors, etc.? Was there a decent sample size? And as I said, the answer was often those quality standards weren't met. And the reason for that is in the previous slides. There's not been the funding to do a decent job. And so many of the studies have been done on the back of master's or doctoral studies, which aren't well funded. But again, there is some hope here. They broke down the quality findings by decade there. On the left, 1979 to 1988. In the middle, 89 to 98. And then 99 to 2008 on the right. And what that is showing is that there's now a few of high-quality studies. They tend to be divided between those that show a positive effect and those that show a negative effect. One of the things that happens when you have low-quality studies being reported is it's only the positive ones that get reported. So we're now moving to a better place. It'll be a place where there'll be disappointments because the better quality, you know, the more likely you are to be able to publish results that don't show a positive finding, as you know, should be the way in good science. The JPND have published their research strategy just earlier this year. Again, it's on their website. And this is what they say about psychosocial research and psychosocial interventions. It's largely derived, the evidence base, from intensive and short-term studies that don't readily translate into real-world settings. Improved outcome measures are required, they say, that better reflect patient and carer perspectives. So there's a challenge for the psychosocial research community to respond to those criticisms. So then we come on to Interdem, and perhaps that's one way in which we're trying to respond and take forward the field of psychosocial research. It began in 1999. Our colleague, Dr. Esme Moniz-Cook at Hull University, was funded by the European Commission to do a project around psychosocial research, and she brought together a multi-professional group from 4 European countries at that time of people who were known in the field and who had, some of them had other European funding. And it was agreed at that time to form this Interdem, early detection and timely intervention in dementia. I must say that the science of acronym making has really come on, hasn't it? I think in the first presentation this afternoon, there's some wonderful AAL acronyms. It's, every research team now has to have a dedicated person, you know, whose job is purely to make up acronyms. And so over the years, it's been really important to not just have electronic communication, but to meet face to face, because that's where you get to really be able to work on ideas together. And Zamora in Spain was our first meeting, and then Maastricht a couple of times. You notice that often we've been able to link up, and this has been really useful with Alzheimer Europe conferences in places like Maastricht, Prague, and Killarney in Ireland, Paris, and so on. Esme, unfortunately, is unwell at the moment, so wasn't able to join us, so I thought I'd show her picture in Thessaloniki. And then this is the group meeting. It seems ages ago, but it was just this Thursday here in Vienna. Don't worry, I'm not going to carry on showing you a series of photos. Here's us in front of the Eiffel Tower. Here's us in front of the Colosseum. It's not like that, but those face-to-face meetings are really important because you can really get to grips with projects. And the meeting we had here today, on Thursday, was all about working out various research proposals that are going to go forward. We've had already a number of projects funded by the European Union. I won't go through all the details of them there. We were very happy to collaborate with the Alzheimer Europe Eurocode project, which was so important. And currently, members are involved in the IMPACT study, which is a study around quality indicators in palliative care, looking at bringing those in cancer together with those in dementia. A number of publications have arisen from this work. Many of them are among the most downloaded articles in various journals. And as well as the academic papers, Esme and Jill Manthorpe have published an edited book, which is very practitioner-based, about different sorts of psychosocial interventions, which has done extremely well because it's very practice-based, but practice-based on evidence. And they're now working on a second edition of that book. What's been achieved over those years since 1999? Well, we've now got a membership of about 117. I have to update this. It's now 20 countries, I was informed earlier today. All the members are actively engaged in psychosocial research, and that's what makes it such a strong and important network. We also welcome, of course, representatives from organizations like ADI and Alzheimer Europe. There's a number of disciplines involved. I won't read them all out, but it covers a good multi-professional range. And there's a tremendous commitment to the network in that there's not funding often for people to come to the various face-to-face meetings, but we had 45 people here, we had 50 at our meeting in London. Almost half the membership are able to get involved in that way, in a face-to-face way. And one of the great things over the last couple of years has been, as JPND's program has developed, we've had the opportunity to be able to influence that, and our chair, Mira Vernoy-Dassen, has been on the scientific board, and others have been involved in various other ways contributing to that, trying to make sure that psychosocial research is properly represented in that program alongside the other important areas of research. So what are the prospects for the future? What are the ambitions? Well, the key thing is to really raise the quality. We had a workshop just over 12 months ago, which raising the standard. What we want is good psychosocial research, which stands alongside other forms of research and is seen as credible and capable of taking the field forward. We do need to look at outcome measures. It's been really great over the last few years to have developed quality of life measures that people with dementia can report on themselves. That was a major breakthrough, but we need to develop more work on that. We've published our review of outcome measures that's, again, been very influential, and it's good that more and more people are using similar measures because it makes it possible to compare more easily across studies. We need to address implementation, and this is where research into practice comes into its own. And the problem with psychosocial interventions is you can't package them up into a pill, so that the pill is the same whether it's delivered in Istanbul or London or Helsinki or wherever. The psychosocial package, if you do package it, is dependent so much on who delivers it, on the context, on the system, on all those things. And those things do make a difference actually to pills, but they particularly make a difference to psychosocial interventions. And getting the consistent delivery. And whenever we're doing these systematic reviews of different interventions, take cognitive training, for instance. Reviews are published on that, and then we look at the different interventions, we find people are doing very, very different things, but it all comes under the same name. And then it gets really confusing to be able to say, does this work, does it not? Because what's it? It's different in different places. And so this is why it's really important to be clear, not to standardize everything, but to make sure that there are manuals about particular approaches and to show clearly the differences between different implementations of approach. And we need to do this across Europe because there we get the diversity of culture and systems that really test what is the essence of the intervention that we're trying to work on. And there's a number of really good examples of where people from Interdem are trying to do that with a whole range of interventions, including Maud Graf's OT intervention and the meeting center intervention, for instance. I guess I emphasized early on randomized controlled trials, and I suppose the reason for doing that was that one of the reasons that psychosocial research was always looked down upon was that our colleagues in other fields would say, well, when you do a randomized controlled trial and show that your intervention works, then we'll take it seriously. And so we did. But we recognize that randomized controlled trials aren't actually the be-all and end-all of evaluation research. They have their place, but they're only part of the picture. And one of the things I think we now have to do as a strong network is to say, here is a way, here is a framework for evaluation of these complex interventions that really takes on board the particular issues around dementia care. And get that across and get that accepted as the new gold standard, if you like. Yes, it will include RCTs, but it will also include process evaluations. It will include implementation research right from the outset so that we're not just producing things that go on a shelf, but can actually be put into practice. Drug trials are a useful analogy, but they only go so far with certain interventions that can be highly packaged and manualized. Assistive technology, we've heard a lot about that, but of course there are particular challenges in evaluation, not least that the technology has changed by the time you finish your 3-year follow-up of your randomized controlled trial. How getting smarter evaluation is going to be really important there, and we've got a task force that's working on that. Also, I think one of the things that was beginning to happen, and maybe it's due to different funding systems in some countries, that psychosocial interventions were beginning to be prescribed, to almost be done as a medical, or an intervention within a medical framework. Taking people with dementia out of normal life to go and do their cognitive stimulation, or to do their music, or whatever. Well, why not actually do it in the mainstream? You know, how can we actually make therapy as life as therapy, and make sure that our interventions are truly about social inclusion? And this is where I think some of the creative arts projects really have a benefit, and we've been hearing a lot about dementia supportive communities, and there's a real role there too. As Stephanie mentioned, I've been doing this for more years than I should really care to mention, and we're very mindful that there's so much to do. We need to build the capacity. And we're very struck by a number of very good PhD students across Europe who are working on these areas, and we want to encourage them. And we're talking of setting up an Interdem academy where we can organize exchanges and programs for PhD students and postdocs to really build them into the leading researchers of the future. And then finally, in my future prospects, just the other day, the email came out from JPND that they're going to launch a call in December this year, with submissions a generous 3 months later. A call for European research projects on the evaluation of healthcare policies, strategies and interventions. So there's a whole lot of things that are included there, including care pathways, psychosocial interventions, end-of-life strategies, educational programs. Studies should benefit, of course, people with neurodegenerative diseases and their carers and families. And what we want to do is to make sure that some very strong, high-quality proposals that go into that, and that's one of the things we were working on Thursday, was working on particular proposals that we can take forward to that. And we hope that there will be lots of competition, because that competition is going to be good for raising the standard. So thank you all for sticking it out this afternoon, but we've got a special thanks to say to Jean-Georges and Alzheimer Europe. They've been tremendously supportive to us over many, many years, and we hope that relationship will continue. That's our website. Please visit that and find out more. Thank you very much.
Thank you, Professor Woods. It's because of people like you that the field has advanced so rapidly, and that we have seen in our own lifetime, I have to say, such a change in the picture that we have today of people with dementia. I think, thank you so much for your engagement and enthusiasm that is influencing so many people around the world and in Europe to change practice, and also to have the strength to let feelings out. When you are working in care, I know of many people that work in practice that they say, well, we didn't dare using methods. We felt like that, but we actually didn't dare to use them. But I think now they're coming forward and they're using their really good clinical skills to help people with dementia. Thank you. I can't see anybody. Well, I have a brief question. Which actually concrete manuals and protocols are available to researchers and can be used already for studies that have been developed by the Interdem group, for instance?
Okay. Yeah, so in my abstract I mentioned manuals and protocols. The most obvious ones, I guess, would relate to cognitive stimulation and cognitive rehabilitation and reminiscence work. But obviously more graphs, OT intervention is highly protocolized, and similarly Rosemarie Dross's meeting center intervention. I think there's a number of examples that we could go around, you know, that for each randomized controlled trial, you're likely to see a very clear treatment protocol. And if it's not actually published, then the authors of that trial should be able to supply it for you. Thank you.
I think it's important that not everybody is inventing the wheel over and over again. So these networks, I think, are very important, and we should take advantage of the knowledge that's already there.